Good morning, everybody, and welcome to Mount Sinai. Here on this nice warm May day here in New York. Obviously, we're all in the middle of this pandemic, and as part of our ongoing educational effort, we've decided to continue on with a panel discussion rather than do a live case here at Mount Sinai. Part of the reason for that is that our governor has asked us not to do any elective cases, but yet still just continue with urgent or emergent cases. And obviously, setting up a live case at this time would mean that it's elective. But after speaking with our team, our both cardiology and vascular surgery, we all felt that there's still ample room for us to be able to discuss a lot of the issues that have gone on over the last 3 months. The last webcast we did, which was a panel discussion generally on considerations in management of COVID patients, focused on peripheral arterial disease, and that has been incredibly well received. And we had a lot of email questions and a lot of questions that was sent to the website. And we appreciate all your questions, and we've taken the time to really answer a lot of the questions, including Dr. Olin, Dr. Mako, Dr. Luxstein, and Dr. Ferries. That particular webcast is also archived in ViewMedi, as well as our website, liveperipheral.interventions.org. So without further ado, I mean, the topic today is really going to be about acute limb ischemia and critical limb ischemia. And as we did last time, we emailed out to our audience to ask questions, and we've got quite a few questions. And I'm live here, and as is Serdar, to go ahead and get any questions from you so that we may answer any pertinent questions that you may have, like you did last time. So I'd like to introduce our faculty. First of all, to my right is Dr. Karthik Guja, who is the Associate Director of the program and an Assistant Professor of Medicine here at Mount Sinai. Below him is Dr. Vishal Kapoor, who is the Director of Peripheral Interventions at Mount Sinai Morningside, and he's also an Assistant Professor of Medicine. To just below me immediately is Daniel Hahn, who's an Associate Professor of Medicine, of Vascular Surgery and Surgery here at Mount Sinai, and one of our close colleagues. To his I would say, I guess, right would be, forgive me, I don't know right and left, is Dr. Ajit Rao, who is Assistant Professor of Surgery and Vascular Surgery here at Mount Sinai. And above Ajit, and to my right, is our very own Dr. Serdar Farhan, who is the Assistant Professor of Cardiology here at Mount Sinai. So I'd just like to start off with a general question, I guess really directed more at, I'll start with Dan. Dan, well, one of the questions that we've had is really to talk about how has your practice changed? And there's a specific question which I think is very pertinent, because vascular surgery at Sinai really covers the ER. You guys see a lot of the acute patients that come in through the ER. And one question I think really is reflective of what people's concern is, and that is, did you, Dr. Hahn, encounter a reduction in the presentation of CLI patients to the emergency room during the pandemic?
Thank you so much for having me, PK. It's a pleasure to be here with all of you guys this morning. So our practice has been kind of undergoing a lot of changes since the start of the pandemic. As you know, and you described, a lot of us were deployed to ERs and ICUs. Luckily, all of that deployment has ended, and all of us are kind of back to being vascular surgeons again. And as we start talking about how to reopen our practice, we've been kind of doing it very safely. We're by no means up to full speed. The biggest thing about opening is to open safely. So our waiting areas are still very much empty, and that's the ultimate goal, to make sure that there's not too many people sitting next to each other. So our office hours has been, we initially opened at seeing one patient an hour, which for a surgery office is an eternity. Initially started at one patient an hour, and it's come down to 30 minutes an hour at this point. And even now, we're trying to make sure that in between each patient, things are kind of cleaned very thoroughly. Going to the specific question about presentation of patients during COVID, you're absolutely right. It's the biggest issue was that a lot of the times, as you know, and all of us who treat CLTI and CLI, you want to get to the foot early. You want to make sure when there's a little bit of ulcer tissue loss, that's when you want to get the patient to make sure that you can achieve limb salvage. one of the major things was that patients with smaller ulcers were not getting the routine checkups that they did, and we weren't seeing the kind of minor to moderate disease processes that present to the ER as much as before. When patients presented to the ER, and Dr. Rao can also speak to this, is they were very advanced in their disease process. Patients who had not gotten their feet checked for a very long time would show up with extremely advanced disease with nearly unsalvageable feet. You know, it's something that we're looking at, but probably the amount of amputations that were actually done during COVID was fairly high, mainly because of how late in the disease process these patients presented.
Ajit, any comments on your end about that?
Yeah, first off, thanks again for having me here. I completely agree with what Dr. Han said. Because of the delayed presentations, delayed care, you know, a lot of the procedures we did, a lot of the percentage of cases ended up being amputations. Can you guys hear me?
Yep.
Yeah, sorry about that. So a lot of them ended up being, you know, amputations that were potentially preventable, and you know, I don't even think we've seen the full effect of that yet. I think in the upcoming weeks to months, we're going to see more and more of these cases that, you know, present with worsened gangrene that, you know, potentially had preventable amputations.
So the other thing is, Dr. Guja, I mean, I know you work at both the inpatient and as an outpatient setting, and you are also part of a very busy practice in the tri-state area. What have you seen in your care of these patients, and how are they presenting in the outpatient setting, since they're coming to the hospital late, so that really not much can be done for them? Have you seen a change in your patient presentation?
So I haven't seen much in difference per se. I definitely saw lowering of CLI. They're not coming in at an early ulcer stage, as Dan and Ajit were saying. I don't see that much ALI. I don't do ER calls or anything, so vascular, but definitely CLI presentation was gone down. They're coming very advanced in the disease, for sure. I had a couple of patients who had advanced CLI. Probably they had CLI and they probably had COVID, and with COVID they had some kind of thrombotic events, and they came in with gangrene. Very expedited presentations, like they were like ulcer presentations, and in 3 weeks later they suddenly become gangrenous. I've never seen this advancement of CLI presentation before. At least I don't know if it's just the disease pattern or they had underlying COVID, but most of them had no symptoms at all, except their advancement in CLI. And when I sent them for COVID, I did COVID testing in my office for CLI patients. So when I did it, they were positive, and I had to send them to the emergency room. A lot of them got amputations, unfortunately, as same as Dan and Ajit, same way, which we would have normally in regular settings definitely prevented. But in this pandemic, I think we didn't have much of a choice other than to send them to the emergency rooms. But again, we could not do much procedures in the outpatient setting either, because we were limited to what we had to do.
So in that follow-up question, I want to ask Dan this question. Was the question that came in was the lockdown with the closure of podiatry offices? Do you think that's part of the reason why patients, were afraid to go to the ER? And didn't want to come to the hospital to be seen early, couldn't go to an outpatient office as a podiatrist who might have been able to siphon the patient over to one of us to be able to take care of. Do you think that was the major issue in terms of these patients not being treated early enough?
Absolutely. I think if anything that this COVID pandemic has taught us is that there's a reason why we have these surveillance protocols for patients. There's a reason why they're plugged into their podiatrist for regular wound care. And there's a reason why we bring these people back for surveillance of their lower extremities and to make sure that things aren't advancing. The ultimate goal of that is to catch something before it turns into a major problem. And I think that kind of system broke down in the middle of the pandemic out of necessity, just because they need to make sure that these offices were empty and nothing urgent was being seen. But once again, I think it kind of reaffirmed that our surveillance protocols and bringing patients back and seeing them on a regular basis is what is actually needed, because when that broke down, you could see kind of the things that we're discussing here.
Great point. Dr. Kapoor, a question for you, and also Dr. Sardar. You please weigh in if you can. I think this question is really directed at a patient who had stable PAD, and the question is, in patients with stable PAD, had you seen a worsening of their symptoms or a rapid progression to CLI in the RALI in these patients?
Well,
Michelle?
Yeah, so thank you, PK, for the question, and thank you for organizing this. So, I mean, essentially, in an outpatient setup, especially in patients with known stable PAD, because we were able to establish a telehealth medicine, which I'm sure we'll elaborate on how it plays a part in the PAD management, there was still a consistency of the symptoms, meaning there was not much worsening of the symptoms noted if the patient had a minimal availability to the physician, either by a phone call, if there's worsening system, or tele face-to-face, or worst case, urgent care / hospital. So the patients who could avail these facilities still had stable disease per se, but there were certain age group of patients, especially the older patients who had limited availability of medical care in this time of pandemic, and people who are nursing home. Those of my patients really had a downhill progression where they rapidly progressed from, let's say, like Dr. Guja talked about, from a stable PAD CLI rapidly into an associated gangrene and an ulcer loss. So I think it's all about, like Dan talked about, the surveillance process being disrupted, the medical care being disrupted, causing worsening of the symptoms. But otherwise, whatever we could do from our side did help patients at least stay at that level and not try to get worsened. But of course, there is a certain category which really got things to make bad.
And Sardar, I asked you to weigh in because the question is in Europe and also in some of the literature that's been published. There's a question of thrombosis formation, and we know Ajit and our vascular surgery colleagues, as well as our colleagues in Europe, have talked a little bit about that. But have you heard or seen in your practice anybody who is rapidly progressing from a claudication situation to a CLI or ALI situation?
I mean, we had a patient who had a CTO of the SFA, and we treated this patient like 6 months ago with 2 drug-eluting stents, and she was fairly stable. Until like 2 weeks after the pandemic started, she started complaining of lower extremity pain, progressing towards resting pain. The situation got that worse that we decided to bring her into the clinic to do an ultrasound investigation, and we found that she had an occlusion of the SFA stent. So now we can suspect that the patient might be incompliant. She was still smoking. She was diabetic. So we took her for an angiogram, and in meanwhile we performed also, because of the precautions for COVID, we performed a PCR test. And while we were performing this angiogram in this patient on the PUI, the COVID test returned back positive. So one can assume that the patient had a progression of the disease, and she was an intermittent claudicant patient who improved after intervention, probably had mild ISR, but maybe her COVID infection got her a further thrombotic push towards resting pain. So unfortunately, we were not able to intervene or send her for surgery at that time. So we decided to become a little bit more aggressive with medical therapy, with furthermore with anticoagulation. So we started her on rivaroxaban at that time, and not only in the low compass dose, we started her actually on a therapeutic anticoagulation dose, which she tolerated, and then after 2 weeks later, she came back for vascular surgery, and she received a bypass surgery, actually.
Yeah, by Dr. Rao. Yeah. But I have a question for Ajit and Dr. Rao and Dr. Han, and I think this kind of is a nice segue into that, because it really affects our vascular surgery colleagues and cardiology colleagues. The OR, obviously, it's a really big deal. So what they're saying is there any case with critical limb ischemia, not acute limb ischemia, okay, where you might perform an angiogram while the patient's SARS-CoV-2 test is pending? And what is the current algorithm in our system regarding these kind of urgent emergent cases where you don't know the COVID status of the patient? And I guess for Ajit, what's the protocol within the OR? And for Dan, how do you protect yourself and the staff from exposure? Let's break it down into 2 parts. Sure. Ajit first.
Thank you. So for the current policy is that all patients going to the operating room need a COVID test. Obviously, in the case of emergencies where you don't have time to wait for the test to come back, then you can proceed. But you would treat that as a patient who may have COVID, so you take all the precautions for that. In our hospital, those cases get done in a separate building and in a separate area away from other patients. So that's so that helps. So that's the current protocol. Certainly, patients that present with emergencies or acute limb ischemia, then you would, while the test is pending, you proceed anyway, and then you could figure out the disposition afterwards of where the patient needs to go once the test is back. I'd have a very high threshold on operating on a patient with CLI. If it can, especially if it can wait a couple hours, because that way you can get a test back. If it does come back positive, you may consider exactly what you just talked about in the last case, just delaying the procedure for 1 or 2 weeks to make sure the patient doesn't become symptomatic from COVID. I would say it's probably important to have a higher threshold on patients with CLI, at least until you get some testing.
And from what I'm understanding, you have a dedicated OR that's meant for patients who are, under PUI, basically, per person under investigation, kind of situation. So you're not mixing patients who are positive, but potentially with patients who are negative in the OR. Is that true?
Exactly. So there's a separate area, separate building, in fact, where those cases are done. And, basically once you go into that room with your PPE, you don't leave until the end of the case. There's a staff outside to help grab things that you may need during the case. So it's been well planned out, thankfully.
Yeah, and Dan, that was kind of for you as well, in terms of obviously you have a separate OR. I guess Ajit is saying that there's special precautions you're taking so the patients aren't, that you're not exposing others and yourselves while you're in that room. Is that true?
Right. So one of the things I want to specify is that precautions are taken for every, because you have to remember, COVID test, the PCR test still has a false negative rate. So exactly for that reason, no matter what, every single case is almost treated like they're COVID anyhow. But patients who are truly tested positive for COVID have a completely separate OR system, completely separate recovery system, just so that those patients have a rate of improvement, so we kept them separate altogether. Now, going back to kind of what Sardar was talking about before is, one thing I think that we need to remember is that even before COVID, we would have our interventions go down. We've had bypasses that presented occluded during this COVID pandemic. And I don't know, so I don't know if that's coincidental that these things are failing during the time of COVID, or that there truly is a hypercoagulable push. Now, one of the reasons why the COVID status, I think, is very important is that it really affects our post-operative medical management. So typically, if you did a lower extremity angiogram and a tibial revascularization, that's a patient that I would have put aspirin and Plavix on. But now in the setting of COVID, if I know that the patient is COVID positive, I'm treating them with aspirin and full dose anticoagulation, just because we know that these patients are known to be hypercoagulable to some state.
That's a great point. Before we get to anticoagulation, where we're going to go a bunch of questions on that, I want to ask Dr. Gupta and Kapoor. First, Karthik, actually, can you comment in the outpatient setting, which I think is very important, right? There are a lot of OBLs, a lot of ASCs now performing these procedures. Is there an algorithm that you're using, being a busy interventionalist in your lab, to protect yourself, your patients, and your staff?
So in the OBL setting, I don't know how other OBLs are doing, but in my OBL, I only do one patient at a time, right? And all patients are COVID tested a day before. So we get the results back in 6 hours. So they do overnight check in the LabCorp. So we usually send them in the evening, and the next day morning we get it. Unless we know the COVID results, we don't do patients. But even if they had any symptoms or they have developed any symptoms in the past 1 week, we usually hold off unless they are CLI. If they are CLI and they had some minimal symptoms and they're COVID negative, I usually do the procedure for CLI patients, and one patient in 1 hour. Until that patient leaves the OBL, the next patient is not brought in. I mean, clearly it is not extremely viable, but in these situations, I think safeness, to be safe, is more important than being viable. And only CLI. I don't do any claudicants. Luckily, all my claudicant patients are still holding up. Now they're complaining because I think they're coming out and walking. but they've all been fine. I didn't have any acute events for the claudicants. None of the claudicants have moved from stable situation into CLI or something like that. CLI patients have advanced, but not claudicants. They've all maintained very, very nicely. So I'm still holding off on all the claudicant patients, only CLI, unless they have like resting issues or any new skin breakdown. But definitely one patient, that patient usually takes around 2 hours to recover. So that patient is moved into a private room, and then a patient is brought in. And the third patient doesn't come in until, let's say, first patient leaves, cleaned up completely in that room, and the second patient goes into that sterile room until that patient comes in. So yes, usually we end up having like 3 or 4 patients in the whole day. That's it.
Fantastic. So I think for the audience, we're going to go into our next part because it's 8:15. And I think at this series, what we've done is we put together a series of cases that are going to provoke a lot of discussion. And I think we're really going to hit on, I know there's like 4 questions on what Dr. Hahn hit on, is whether we've changed our anticoagulation regimen. So why don't we start with the first case with Dr. Rao on behalf of the vascular surgery team, who's been kind enough to put together a couple of cases. And then we have a case from our team as well. But so how the format's going to be is we're going to present the case, talk about, obviously the status of the patient, how we would approach it given the current pandemic, and then whether that's different than how would we before or after this pandemic is over, and then we'll go through the intervention, and then we'll discuss anticoagulation on a case-to-case basis. So Ajit, do you want to kick us off?
Sounds great. All right. So yeah, this is one of, I would say, many cases we experienced during the COVID crisis of acute limb ischemia. So this particular patient presented recently. So she's a 37-year-old female, and she presented with acute onset of right leg pain and numbness. Of note, she attested to some mild respiratory symptoms 1 to 2 weeks prior, but on presentation, those had completely resolved. Her medical history was only notable for hypertension and diabetes, which were well controlled. And she had no prior surgeries to her legs and in fact, no history of peripheral vascular disease. And she was on an aspirin at the time. Then in terms of her physical exam, so she was tachycardic, but otherwise her vitals were okay, and she was satting well on room air. Her right leg appeared acutely ischemic. It was pale, it was cool. She only had monophasic signals in the foot, and her other foot had palpable pulses. And she had some numbness, but her motor was okay. As is protocol for all patients, like we mentioned, that go to the operating room, a COVID test was ordered, and it actually came back positive. So I'm gonna just show some images, and then I'll stop there. So this is just some representative cuts. So her she underwent a CTA, and her iliacs and everything were okay. Coming to the common femorals, you'll notice that there will be a abrupt cutoff on the right side there, in the right common femoral artery, and then we didn't see a superficial femoral artery come back, but you can see a little bit of opacification further in the thigh, and then really below the knee, it's hard to tell if there's any contrast getting down there because of the timing or if anything's actually open. So this was the report from the CAT scan, which is essentially what I just went over. So I'll stop right there because that's essentially her presentation.
I think that's a great presentation. So, and it's obviously something that's very concerning in somebody here. Just a couple of questions. I mean, Ajit, was there any EKG with atrial fibrillation or anything like that? Because we know that COVID-19 patients can sometimes have arrhythmias. Have you had? Was there anything like that going on?
Yeah. So she thankfully, since her motor was intact and her leg was stable, she underwent some testing. So her EKG was sinus. She actually had an echo done, which was normal. Didn't show any thrombus, anything like that. A TT, and she even had some hypercoagulable labs sent, which all eventually came back negative.
So Sardar, can you comment on the, I wouldn't say the incidence because we really don't know, but on the ability of COVID to create a cardiomyopathy and or arrhythmias in these patients? Because I think for our multidisciplinary audience here is beyond cardiology, I think it's important for vascular surgery and IR to know that, that this thrombus could have come from elsewhere. So can you comment on what's been going on with the literature?
The situation with creating a myocarditis or a myocardial injury during COVID is more, we believe, due to a cytokine storm. So the COVID virus enters the body, creates an inflammatory reaction from the body through endothelial cells, through affecting myocardial cells, and the virus creates this inflammatory reaction, and the body has an amplified, in some cases, an amplified reaction with increased cytokine release, which in turn activate the coagulation cascade. So some patients occur with large artery thrombosis, with pulmonary embolisms, or with pulmonary thrombosis, which generate in the lung apparently. And the cytokine storm can lead to a reaction similar to that broken heart syndrome, like the Takotsubo cardiomyopathy, stress cardiomyopathy, affecting the heart in that way. And with the affection of the heart and with reduction of pump function, some patients might develop arrhythmia with atrial fibrillation, and this is actually then the end of this vicious cycle, because the virus itself is in some cases creating a hypercoagulable state. Then you develop also atrial fibrillation. You have stasis in the left atrial appendage, leading to stasis. This is the Virchow trias, which we were all educated in. And then you develop a thrombus, and this thrombus might migrate to create a stroke or an ALI in some cases, because I believe there were some cases in Sinai where the patients developed ALI with huge thrombosis, and incidentally they were also discovered that to have thrombosis in the heart. So atrial fibrillation is a common finding in some of these patients.
That's a great description. So I mean, I think it bores to our workup of these patients. I mean, like what Dr. Rao was saying, hypercoagulable state, workup for look at the heart, make sure it's not a thrombus formation from a cardiomyopathy, which again may preclude OR management and anesthesia and so on and so forth. So that we just have a question that's sent in, and I'm going to throw this to Dan, even though it's a JITS case. So Dan, it says here, in this kind of patient who has acute limb ischemia, what would your approach to therapy be? And he's a vascular surgeon from Atlanta, Georgia. He's saying that would you do open? I'm sorry, Fogarty. I can barely read this here. Would you do Fogarty, or would you do a catheter-based therapy for this patient based on the COVID status of the patient?
Yeah, so this is one of our partners' procedures. So you'll kind of see the direction that it went, but you're absolutely right. Majority of the time, whenever it's an embolic phenomenon, I think both scenarios can work very well. The patient's acuity of presentation is probably the most defining thing. If the patient has significant motor loss and sensory loss, that's the kind of patient I take emergently for a open revascularization, because at the same time, you're most likely going to end up doing a fasciotomy. As just going to be acute reperfusion injury. And a patient who presents a little bit more subacute, you might have a chance and an opportunity to do a catheter-based thrombectomy using either suction thrombectomy or pharmacomechanical thrombectomy. And I think according to Dr. Rao's presentation, this patient had an opportunity for both, honestly.
But the question, I think, is maybe Ajit or Vishal can take this one, is really about the COVID status of the patient. Utilization of resources, obviously the being COVID positive, with the unknown issue of if they need general anesthesia, God forbid, during the procedure, you can never predict. And so would this be somebody where you would kind of holistically look at it and say, hey, this is something I can manage with a catheter and not risk anesthesia and intubation? And I think that's where they were going with this question. So Vishal, you want to take a peek?
I think it's a very good point, especially in these circumstances. Always good to have the collaborative, multidisciplinary approach. You talk to the vascular surgeons, the endovascular specialists, whatever it might be. And then the whole idea is to prevent exposure of the team, of the services, and of the all the essential needs for focusing on the patient per se. So like Dan said, if it's a subacute presentation, I would be probably a little bit more conservative and follow the patient to see clinically how the patient does. In this case, if the patient has a rapid progression, including severe loss of sensory or muscle stuff, then we, of course, surgery, and it's a young patient, we have to save whatever we can, so try to salvage as much as we can, and then we do the surgical part. But if it's a subacute presentation, I would probably lean more towards the less aggressive approach, which might be doing full anticoagulation, following up the patient routinely, and if need be, do a catheter-based focal treatment to buy some time till the time we have a definitive therapy, which might be a bypass or an open fogarty with fasciotomy per se. What do you think, Ajit?
Yeah, so actually, let me just hop back in there real quickly. Is that
right?
Exactly to PK's point, one of the things that has changed our decision-making process throughout the COVID pandemic is really the use of ventilators, right? In the beginning, we're all about ventilators, make sure we have much. And in the beginning, a lot of the therapy and our response to the COVID patients was early intubation so that it can be done in a safe setting so they can really protect everyone else around you. The worst situation we thought would be an emergent intubation in the middle of the night without adequate PPE that might expose patients. But now, fast forward 2 months into this pandemic, and really one of the things that we've changed to is try to really prevent patients from being intubated. And once they go on, they end up staying intubated for a long period of time. And exactly to your point, PK, it's in a situation like this, especially for semi-elective, this is an urgent procedure. For an urgent procedure, if there's a way to get by without intubation, you're absolutely right. That's every step of that needs to be considered.
Yeah.
Right. But the only caveat is, remember, intubation is a closed circuit intubation. So technically you are not, if you get intubated, you really don't spread the virus because it's closed circuit stuff, rather than if the patient is wide awake and is just spreading this virus in the stuff. But of course we have to utilize our resources and make sure we do what's right for the patient.
But also I think Sardar makes this point very well. I mean, it's a utilization of resources, right? I mean, number one, if you can save an ICU bed, a prolonged ICU bed. I'm thinking the lytic patient might have to go to an ICU.
Right.
But if you can do, say, angiojet or power pulse spray, you can obviously save an ICU bed. You might be able to handle the thrombus, get the patient out, and get them to a recovery floor rather than an ICU bed. Second, when you intubate them, the process of intubating is obviously the time when there's the greatest amount of exposure to our anesthesiology colleagues who are going to be doing that intubation, although now there are new techniques as described by the NYU folks and so on and so forth on how to do it, but yet there is still a level of exposure. And I think that's why this question is very relevant that he asked for. And I think, so Ajit, what did you end up doing?
All right. So actually, this is kind of a great example of everything we just talked about. Can I get my slides back up? So in this case, this actually wasn't, this was one of my partner's cases, but what he kind of considered the anesthetic like we discussed. He was worried about having to intubate this patient, especially with their COVID status, whether they would get extubated, whether they would get a worsening pneumonia and, require a trach or go into respiratory failure. So he considered all those things and also the acuity, like we mentioned. Since the patient had stable symptoms and motor was intact. So he elected to try to fix this with a catheter-based procedure. So the patient underwent an angiogram and then an angiojet thrombectomy of the area. And let me just show you the slide here. So here was his initial angiogram here. And so you can see what looks like acute thrombus we're looking at the femoral head area right now. So you can see acute thrombus in the common femoral artery extending into the profunda, and then you see a little bit of superficial femoral artery coming back. So, most likely an embolus sitting right at the bifurcation. So he did an angiojet thrombectomy, and he felt there was still significant residual thrombus. So he actually left a lytic catheter in and overnight, and then took the patient back the following day. And given the extent of thrombus that was still there, he ended up just doing a a cut down under local, and he did a Fogarty and removed all the thrombus. And he thankfully was able to do that without requiring general anesthesia at the end of the day. So after that, the patient had palpable pulses and was left on anticoagulation and ultimately had an uneventful course, thankfully. I was discharged a couple days later.
Fantastic case. Question to head back to our anticoagulation issue. There's a follow-up question here, which is very clear. In this kind of patient who does not have any pre-existing factors for the thrombosis, would this be somebody that you would need to put on dual antiplatelet therapy or isolated antithrombotic therapy? So why don't we send this to Serdar first and then Dan?
So that's a great question. We were taught as cardiologists to give every patient aspirin, and after an intervention, certainly a dual antiplatelet therapy with Plavix at that time, and now modern antiplatelets are also emerging. But we learned from COMPASS trial and from Voyager trial that adding an anticoagulant, especially in a low dose, might be more helpful and better with reduction of cardiovascular events. And it looks like during the COVID pandemic, we learned even more about that, because we are realizing that the process is not only a plasmatic thrombotic process, but it also involves platelets, because large vessel thrombosis, like for the stroke cases, which were presented in the New England Journal by Dr. Oxley and his team, showed that a possibility for, or a good role for antiplatelet therapy has to be appreciated or discussed, at least, while treating the patient with anticoagulants. So we believe that giving a dual therapy with maybe clopidogrel plus a moderate or high dose anticoagulant in this kind of patients would be helpful for at least the next 90 days after this intervention. And after that, I believe it's the best way to reassess the patient and reassess the bleeding risk and the thrombotic risk. And once you scale them and put them into a scale and find that the patient is at higher risk for thrombotic or for ischemic events, you continue this therapy. And if the patient's an old patient or has previous history of bleeding or any other determinants associated with high risk of bleeding, you might defer from continuing the anticoagulant and just keep the patient on antiplatelet therapy.
Dan, anything on your end?
Yeah, I mean, I think Sardar makes a tremendous point. I mean, when you take a patient, and there's been case reports a case series out of Spain about this too, that a lot of the times COVID positive patients with zero atherosclerotic risk factors are presenting with these acute presentations. And anecdotally, when surgical thrombectomies are performed, the kind of thrombus and clot that you're pulling out is not just fresh blood clot, but oftentimes you have this kind of platelet aggregate, whiter looking clot, which often kind of was exactly what Sardar is talking about. A lot of the times, one of the thought processes of this process is that there's endothelial damage and associated platelet clumping that acts as the nidus for kind of the thrombosis happening. So we're exactly the same way. And any of these patients that present with acute presentations, they are put on both a platelet and a full anticoagulant. And then the decision will be made in the follow-up exams. You know, if on their surveillance, when they come back in 3 months, they get their ultrasound performed, their vessel has gone back to looking like completely normal, and we would consider taking these things off. But if there is any sign of continued arterial narrowing or damage, then I imagine that person has now going to be on an aspirin forever kind of situation.
And we have a direct question to Dr. Guja. Dr. Guja, in the outpatient setting, I know that it just says you don't do elective cases currently, but in the CLI cohort, are you worried about acute thrombosis, and how do you manage the anticoagulant?
So for the CLI patients, I kept my algorithm very simple. I think nobody knows the answer. I think everybody in this panel agrees with that. I had some discussion with PK when that happened, but all I can say is I kept my algorithm extremely simple. Any cardiac patients, if they were claudicants, if it was just on aspirin, if they had COVID positive, I told all my patients if they were COVID positive to let me know. If they were COVID positive and I knew that they had PAD, I put them on another anticoagulant like Plavix or Plavix usually, most of the times, if they were not. CLI patients, again, simple. If they were already on aspirin, I definitely kept all the CLI patients on aspirin and Plavix. But if I operated in the elective situation, depending on disease, and most of the CLI patients are multi-level disease, and I think everybody agrees with that. So then I switched them to low-dose Xarelto with Plavix on board, at least for 2 weeks during the acute period. But I don't think I kept any CLI patient just on aspirin or Plavix, at least in the elective basis, because I felt like the chances of for them to form an acute thrombus after I operated are much higher. If they developed, even though they were COVID negative, I don't know if they were going to become COVID positive in 2 weeks. But after 2 weeks, I usually take them off of the Xarelto on follow-up. If they're doing fine, I take them off of Xarelto and just put them on aspirin Plavix.
Excellent. Okay, so I think for the sake of time, there's a couple more questions. We'll talk about balancing the risk of bleeding in these patients with multiple antithrombotics, antiplatelets, and I think we'll get to that. But I'm going to ask Dr. Haroon to step in and present his case. But in the meantime, while they're getting set up in that room, I want to ask this, and I think maybe to both Dr. Guja and the panel. And there's a question, we worry about the balance between bleeding and risk, and we know COVID patients do bleed, into the brain. We've seen that, especially, but these are really, really sick patients. So, I think that's part of the question, and I think after this presentation, we'll talk about that. So Dr. Cameron is our endo fellow this year, getting ready to graduate. And so he's going to present a very interesting case that we encountered in the cath lab. Haroon?
Yes, can I, this slide. Thank you so much. So I would like to present an interesting case we just had last week. Okay.
Next slide.
Yeah. Sorry. Can you fix the... I don't know why do I have this box. Yeah. Okay, thank you so much. So our patient is a 87-year-old female with a past medical history of hypertension, diabetes, hyperlipidemia, traditional risk factors for PAD, who was referred for evaluation of a non-healing ulcer to the right foot. That has been going on for the last 4 weeks. You can see the picture of the wound. That looks like a dry, macerated wound. Due to the current situation with the COVID that's been going on, the patient had tried multiple times to follow up with her podiatry office, but could not follow up because of the office not being open. So she was subsequently referred by the podiatry office to come to Mount Sinai Hospital for further evaluation and management. Can you pull up my slides, please?
So we're having a couple of technical difficulties. So let's just go ahead and ask you guys. The risk of bleeding in these patients. Is there any do any of you use triple therapy with aspirin, Plavix, and a novel antithrombotic in these patients?
Not that I don't use it. So for PAD purposes, if I just use two antiplatelet. I mean, if I'm using Xarelto, I either go to aspirin, Plavix. Especially, I just put them on Plavix. I don't even put aspirin. I just go Plavix and Xarelto. I don't know there is any data or anything, but during this period, I didn't really know what to do. So I just picked but definitely not triple therapy.
How about you guys in the vascular surgery?
Yeah. We don't do triple therapy. Oftentimes I'll do a single antiplatelet agent and Xarelto, exactly as Karthik is doing.
Yeah, I'm the same way. Unless a patient has failed multiple times on dual therapy, then I may consider triple, but it's very rare.
Michelle?
No, I agree. I mean, we usually do dual antiplatelet. I've changed my practice where me and Sardar both decided we've incorporated more of Xarelto both in the outpatient and in high-risk inpatient patients who have like PAD and CLI. So high-risk patients coming in, multi-level disease, I have a lower threshold of putting them on low-dose Xarelto, at least for 3 months, and then by doing surveillance ultrasound to see how they respond. Of course, keeping in mind their bleeding and the risk-benefit analysis to see if they can tolerate the Xarelto or not. And if at 3 months, if they're doing fine, I usually like to continue it. But if they have some issues or bleeding issues, I usually hold back on my Xarelto and go back onto my Plavix or any single or dual antiplatelet therapy as recommended.
Okay,
a little bit
like
more aggressive on it.
The slides are ready. Let's get back to the presentation.
All right, thank you so much. So our patient was referred from a podiatry office because of what's going on with the COVID situation. As you can see, her medications include insulin, aspirin, amlodipine, metoprolol, atorvastatin, cilostazol. So as part of the workup, she was sent to Mount Sinai Hospital, where she had an ultrasound done that showed elevated velocities at the popliteal artery level and tibioperoneal trunk and monophasic waveforms below the knee. And in anticipation for further evaluation with an angiogram, she had a COVID testing done with SARS-CoV-2 PCR that was negative. She subsequently went on to have an angiogram done. So there is the representative image, as you can see. The right SFA stent is patent at the level of the popliteal artery. There's a severe stenosis. And below the knee, you can see there's an occluded PT, occluded AT, and a short segment CTO of the peroneal artery. I'll let it run all the way up down to the foot. So the most worst artery that's dominant to the foot is peroneal. So now I'll open it for the panel. That
so this is a great example, and I think we should go ahead and ask our colleagues here, because one is here you have a patient who is obviously having a critical limb ischemia, was being managed at home, and was doing well, and then obviously because of the COVID pandemic has now progressed to this. She obviously has, she's 87, but by other means, I mean, I think she has a reasonable, I don't know about what her comorbidities are, but I think, have you seen in your practice these kind of patients who were relatively stable prior to the pandemic, who are now sitting at home and not taking care of their foot, not having the equipment to take care of their foot, not having visiting nurse services to come in and wound care services to take care of their foot, and then now all of a sudden now presenting with an acute exacerbation of the pain and now coming in for what could be an amputation or some sort of salvage treatment. So let's start with Karthik, because I know he's in the outpatient area, seeing a lot of these patients in his office, and I just wanted to ask you how has telemedicine helped you in managing these kind of patients?
So a lot, actually. I mean, I think, in my opinion, I think during this period, I've realized that telemedicine actually should be incorporated into the future of medicine. I think it helps a lot. I clearly, for us who are seeing CLI patients, telemedicine is not a huge help. I mean, as a follow-up, you can see, but we need to see the wound. We need to feel the pulses. Of course, we need physical exam per se to be done. But I can definitely say I have seen significant number, at least 30% of my patients have progressed in CLI significantly during this period. People who were like with basic stage 2 ulcer have progressed to like stage 4, and in 6 weeks to 2 weeks, which we thought, it's okay, it's a small wound. Some people had bone infections. I don't know what is the reason for it. I don't know why they progress so much. I go into details of if their family members had it, or if they just had it and recovered from COVID. I don't know if COVID has anything to do with it, or just not ambulating itself is a reason for this progression of CLI. But I definitely saw it. And coming to telemedicine, I think it definitely helped a lot, because it's easy. I mean, if the patients have access to telemedicine, if they wanted to really, there were some patients whom I saw literally every other day on telemedicine, just to see the progression to see how bad it became. I had similar patient as just on this presentation whom I had to do the case, because the patient went from just regular having a stage 2 ulcer to stage 4 and was becoming gangrenous in 3 weeks actually. So it's hard to say if there is thrombotic event. I don't know, but when I operate on these patients, it doesn't look like there is a thrombotic event. But all they need, when they are occluded like this, all they need is a small amount of thrombosis. there could be minute amount of thrombosis to just shut off the vessels.
Right.
And they just go from regular stage to like no flow state.
So, but Ajit and Dan, I think, in this particular patient, she was SARS-2 COVID negative. So, I mean, obviously, you're right. She could still have thrombosis, as Dr. Guja was saying. But, I mean, this kind of impact of patients, and I think we're talking about it. We've seen a reduction in MIs. We've seen a reduction in a bunch of these patients, aortic dissections. You guys know about that, and on all this stuff. So the idea would be: are these patients waiting to the last minute, or God forbid, even ending up passing at home because of this great fear of COVID? And how are you dealing with that in the practice? I mean, I think that's the important question here.
So I think, those are all good points. I do think patients, are reluctant to come in. And so they're waiting on these ulcers and the gangrene. And even if it's progressing, some patients have the thought, I'd rather choose my life over my limb at this point. So I do think we are going to see more advanced CLI as a result of that. Some things that I'm personally doing, I think one great tool is what we mentioned, the telehealth. Setting up video chats, calling patients, checking in with them. Sometimes it can be difficult in our patient population because you do have to have some level of tech savviness, but certainly even giving them a call and checking in and getting photos especially about the patients that about that have gangrene in their foot, I think can be useful to kind of triage them.
And Dan, could you comment a little bit, and Vishal, on the limitations of telemedicine in wound care? Because that's one of the questions we're getting is, how is this, telemedicine helping you with wound care, or is it, or cannot help with wound care? Dan?
Yeah, so I think first, I agree with the points that were made. The one thing to consider, it's not even so much that the patients don't want to come sometimes. You have to understand a lot of these patients lost some of the support that they used to have. A lot of my patients lost their home health aides. The people who would normally be the first people to identify problems in their feet and raise the flag and bring them and start the whole process to be seen in the office. So some of my patients are now, I actually don't even know how they're getting around. We're fully dependent on the home health aide who got sick and can no longer come in. The agency has had difficulty in filling those kind of patients as well. So, a lot of these patients are losing the support systems. Telemedicine, in my own humble opinion, it's great, but it does not replace the current surveillance visits that you actually have. I think telemedicine to do a new patient encounter is extremely difficult. Exactly to Karthik's point, you have to see the foot. You have to do the vascular studies in order to know what the circulation looks like. It doesn't replace your surveillance protocol. They still need to come in for their 6-month, 1-year ultrasounds to see what the progression of disease is. I think where telemedicine is really beneficial is adding to the current surveillance protocols and being able to see these patients and their status more frequently in between, since they don't have to come in. You don't need to be in the office. It's very quick. And it adds an element of that. It's really helpful. The times where it's been the best for wound care is when telemedicine can often be done at the time of your visiting nurse going to see the patient.
Yep.
That's like the perfect trifecta. The visiting nurse is at the changing the dressing. You're able to communicate that telemedicine visit with you. You have a medical professional who's looking at the wound. It takes a little bit more coordination, but once it's done, it's actually really a good way to have a trained set of eyes and for you to actually see the wound at the time of the visit.
And Dr. Kapoor, yourself?
I think Dan has made excellent points. I mean, I perfectly agree with him. It's just a combination of having a physical presence and a telemedicine follow-up. So new patients, you really want to see them, assess them, have a good doctor-patient relationship. And stable patients, you can do regular routine follow-ups, easier, more convenient for the physician and for the patient. And it just elevates the whole anxiety of nobody saw me. So I think telemedicine bridges that gap of I've lost and nobody's following up with me. It gives the patient the reassurance. And of course, hopefully it helps us identify problems early on and take corrective measures so that the patient doesn't end up with critical limb ischemia or even acute limb ischemia. So I think it's a good tool to have one, but like Dan said, doesn't replace the primary goal of physical presence.
And Dr. Sardar, I mean, one of the things that we've talked about is of new recent publications about the increase in amputations during this pandemic. Yeah. Do you think part of that in Europe that's been published that we know about is because of the fact that of the delayed presentation to the ER?
I'm pretty certain that it is that, because once the pandemic started everywhere in the world, everything went to complete shutdown. And since nobody of us witnessed the Spanish flu and that pandemic at that time, we are essentially like learning from scratch how to react. So I believe we missed the opportunity to inform our patients as healthcare system, as public health officials, to inform those patients who are critically ill and not COVID disease, that they still need to seek medical contact and not just shelter in place and wait for the pandemic to ease off. Because in Austria, there were publications about a dramatic reduction of ACS presentations, also a disappearance of pulmonary embolism cases in the General Hospital of Vienna. There's a small letter to the editor in JVS published from
New England Journal too, right?
From two Italian vascular surgeons, complaining that they amputated in the same amount of time, the same period this year compared to last year. They had double the number of amputations in comparison to previous years. Similarly, here in New York, they reported just recently published in JACC that aortic dissections are not happening right now. And comparing the incidence or the prevalence of aortic dissections in this year comparing to last year's, there is a dramatic reduction. So I believe many patients, as Ajit mentioned before, they say, I choose my life over my limb, and some patients say, I can survive with chest pain, I can survive with shortness of breath, and they miss coming to the hospital with critically diseases like pulmonary embolism, acute coronary syndromes, or CLI, or aortic dissections, just because of the fear of the COVID. So I believe now is the time for us as healthcare system, a healthcare provider, and public health officials should re-announce that patients with chronic diseases, at least chronic diseases, should feel safe to return back to their regular practice. Because if we keep this process as it is now, we will have a huge increase of CLI presentation. We will continue to do more amputations than we ever did. We'll continue to have heart failures due to missed acute coronary interventions for acute MIs. We will have many patients who will maybe will be found dead at their homes because they had a pulmonary embolism and they didn't seek medical contact.
Great
so
points.
I think this sounds very dramatic now, what I'm saying, but
I don't think so.
I believe that's now the time to announce or to make a safe patient-physician contact again in hospitals.
Excellent.
At least for critically sick patients.
Yep. So why don't we go to Dr. Haroon and finish off this case? I know we did speak with, I believe, I don't remember whether it was Dr. Rao Han on this one. And it was, I think it was agreed as a group that because of her comorbidities, we'll go ahead and do an endo intervention. So why don't we just, Haroon, show us the final. Oh, okay. You don't have the angio. So,
yeah,
okay. So what we did was we just did an endo case. We revascularized the perineal artery, which again actually ran into the foot as the DP. And Ajit, I believe it was you. They're just telling me. So the patient underwent a transmat, I believe.
Yeah. So the patient had a pretty extensive gangrene in the foot. So I had to do a proximal foot amputation. So she underwent that. She's doing fine. We'll have to monitor her very closely. I did have a big discussion with her in terms of doing a proximal foot amputation versus a below knee amputation, given the extent of gangrene, and she's ambulatory. She wanted to save her limb, so we're gonna try tried the proximal foot amputation. So far, she's doing well.
And I think this is a good example of a patient who probably would not have needed a proximal foot. Maybe it might have just been a transmat if she had presented earlier on, or maybe just toe amputations. And I think that would be a great case. But we're just about out of time, and I know Dr. Rao has another case that we'll put up online without discussion, obviously. But I know that first of all, I really want to thank our colleagues, Dr. Han and Dr. Rao, for taking really a lot of time, an hour of their morning, especially as surgeons who start really early. And really appreciate your contribution, both of you. And I can't thank you enough for all the contributions and the support of us as a team. So thank you to both of you, and really appreciate it. One question that came in that's very pertinent, and I just want to take a panel discussion here. Are you wary of using metallic prosthesis in COVID positive patients because of thrombosis? Yes and no. So let's see, how many of you would not use a metallic prosthesis in an endovascular case in a COVID positive patient because of the risk of thrombosis?
No, I would not.
I would not.
Okay.
I would try as much as possible not to leave metal behind if possible.
Okay.
Yeah, I mean.
All right, so we have 3 saying they would not, and I guess 3 saying that they wouldn't mind, right? If they had to, they had to, right?
Yeah, I'd certainly have a higher threshold to do it, but if I have to, I have to.
Okay. Well, yeah, I mean, I always say one thing all the time live, right? Either you poop or you get off the pot, right? So, if you have to use it, you have to use it, right? So, yeah, so I think that's the thing. So with that nice joke, I think it's time to go. And, I think in conclusion, I want to thank Dr. Guja for taking time out of his schedule. Vishal is always part of our team, is here, and as is Sardar. So thank you very much for all of you for being here. So let me just conclude by just saying a couple of things. I think our panel discussion has been very, very clear in really elucidating the challenges that we've seen in the COVID-19 pandemic. But I think these challenges really reveal some of the inefficiencies of our communication with our patients and the methodology in which we currently communicate with our patients. I think Dr. Sardar and Dr. Guja's points, and as well as Ajit's point about using telemedicine to really be in touch with these chronically ill patients, because fear is a very powerful thing, and when you're afraid, you tend to take risks that you may not need to, and I think it's important to be in touch with our patients with either telemedicine, even telephone calls, sometimes calling their families to see how they're doing, and using our resources and in a very efficient manner to talk to the patients. Obviously, the officials who are asking us to, stay home and all these things may not understand the implications of these chronic diseases, but you and I are the ones who see the end product of a delayed presentation to the emergency room. The second important point that was made was very clear, is that I think that the COVID status of the patient plays a very important role in decision making and in the timing of intervention. I think Dr. Rao's case really illustrated how a very young patient without any real risk factors can present with acute limb ischemia, and the elegance in which they were able to manage that patient who was COVID positive using a hybrid approach of endovascular and a modified, I should say, a less invasive surgical approach with a cut down, really showed that you can manage these patients without obviously intubating, without obviously using up a lot of resources, and also really exposing our ancillary staff to a lot of this infection. Dr. Han and Dr. Rao really clearly talked, as did Dr. Kapoor, about how the cath lab, the OR, has dedicated rooms for patients under investigation, and I think that's important to see that in your practice. And Dr. Guja really talked about his practice in the outpatient, how even though he's doing patients not in a hospital setting, but he's able to maintain the same kind of high degree of concern for the patient safety and also for his staff safety. And it does mean reduction of patient volume. It does mean a more scrutinizing of the patient to find out who really needs to go at this current time versus delaying procedures. Dr. Guja also elucidated how you can actually get testing as an outpatient using the current lab facilities that are in your area to be able to be very clear on what the testing status of the patient. And again, Dr. Han talked about in the outpatient clinic setting how a reduction in volume has affected our practices, but it's probably the right thing to do in terms of stable patients who are coming to see you, rather than seeing one patient every 20 minutes. You maybe make it 30 or 40 minutes, have a clean team, ask the patients the pertinent questions about their symptoms, fever, cough, and exposure to COVID prior to actually coming in. And at the end, I think all of us here are within our separation barriers and are not wearing masks. But in our practice, we wear masks. We wear masks in the hospital. We wear masks when we see the patients. Good hand hygiene, and also educate the patients on what are the things they need to do. But I think this is a complex pathophysiology and a complex time. We were hopeful that this little 1 hour session has really helped you to further understand the pathophysiology of the disease process, some of the clinical presentations, some of the effects of delayed presentation, and how to approach these patients. As far as the final comment on anticoagulation, I think the jury's out. But I do believe that you have to have a conversation with the patient, and a lot of times curbside your colleagues. You have vascular surgery colleagues, IR colleagues, vascular medicine colleagues, cardiology colleagues, whoever it may be, to be able to talk about whether you should add an antithrombotic to an antiplatelet. I think the consensus here is not to add all three, because I think there is a higher risk of bleeding. But the question is, the dosing and so on and so forth, and the duration of therapy is also going to be an issue. The pathophysiology, as described by Dr. Sardar, is actually very, how can you say, primitive in terms of our understanding of it. We think we understand it, but I think our understanding will further get better, and our therapeutics in terms of the vascular inflammation will also get better. So in conclusion, I thank you for taking your morning. Great questions sent to us. Our faculty was very honored to be able to contribute, and we will see you next month, where we will hopefully have a live case. So thank you, gentlemen. I really appreciate it, and please enjoy your day. Take care.